Okay, so today we are going to see a very interesting topic in Mudaliar&Menon Clinical Obstetric Lecture Series. So, the chapter is 12th chapter, Causation and Stages of Labor. Very, very interesting topic, guys, and very, very important for examinations. So, first, let's talk about the definition of labor. According to WHO, a normal labor is defined as spontaneous in onset, low risk at the start of labor, and remaining so throughout labor and delivery. So, it should be spontaneous in onset. The infant is going to be born spontaneously in vertex position. Vertex position is normal around 37 to 42 completed weeks. Very important. That is when you say it's a term baby. After birth, mother and infant are in good condition. At present, the period of viability, it varies, guys. In USA it's 20, in UK it's between around 24 and 26. In India, especially, remember, in India the period of viability is around 28 weeks. So next, coming to the most interesting topic, guys, the mechanism of labor. So in order to understand the mechanism of labor, it is important to know three things, okay? One is the architecture of myometrium. What is myometrium? You know, right? The uterus has a lot of three layers: an endometrium, a myometrium, and a perimetrium. So the architecture of this myometrium is important to understand the mechanism of labor, the physiological changes in the uterus during pregnancy and labor is also very important, and the factors influencing the initiation of labor is important, guys. So let's move on. So coming to the architecture of myometrium. So if you look at the myometrium of uterus, so let's talk about the outer layer first, that is the serosa, okay? So serosa, it is a thin peritoneal layer firmly covering the uterus. It extends anteriorly to form the uterovesical fold of peritoneum. Posteriorly, you have the pouch of Douglas. Okay, so what is this pouch of Douglas? Pouch of Douglas is a very favorite MCQ, guys. So let me draw the sagittal section view, okay? So this is the pubis, okay, guys? This is your pubis, and you have your bladder here. This is your bladder, okay? This is your bladder, and behind the bladder, what do you have? You have the uterus. This is the beautiful uterus which is here, and this is your vagina, and behind the uterus you have your rectum. So this is your normal basic anatomy. This is the sagittal view. This is your rectum. This is the uterus. Okay. So, and behind you'll have your sacrum, your coccyx and everything. So this is understood, right? So if you look at here, there is a pouch. Okay, remember, guys, this is basic anatomy. There will be a pouch between the uterus and the rectum. So that this space, right, it's like a pouch. This is like a pouch. So the space between the rectus and the uterus and the rectum and the uterus is known as recto-uterine pouch. Recto-uterine pouch. So this recto-uterine pouch is nothing but your pouch of Douglas. Very, very important MCQ. So why are we worried about this pouch of Douglas? So the thing is, the most dependent part of the abdominal cavity, the most dependent part of abdominal cavity in standing position is going to be your pouch of Douglas. This is a very, very favorite MCQ. So, which is the most dependent part of abdominal cavity in standing position? It is going to be your pouch of Douglas. The next favorite question of the examiners, the is what is the most dependent part of abdomen. If they twist the question as lying down position, then what will be your answer? In standing position, it's going to be pouch of Douglas. But in lying down position, it's going to be your hepatorenal pouch. Space between that is the space, hepatorenal pouch. So hepatorenal pouch is otherwise known as what? Pouch of Morrison. Pouch of Morrison. This is a very, very important. These two are very favorite MCQs. So most dependent part of abdominal cavity in standing position is going to be your rectouterine pouch or pouch of Douglas, and the most important pouch in lying down position is going to be your hepatorenal pouch or pouch of Morrison. So the myometrium has the smooth, it's the basic histology guys, the smooth muscle fibers, the most important layer of mechanism of labor. This is an MCQ, sorry. Yeah, so this is an MCQ. Which is the most important layer in the mechanism of labor? It's going to be your myometrium. So people get confused. They say, oh, the menstrual cycle is happening, the endometrial sheds out, and so they'll be telling endometrium. No guys, the most important layer in labor, we are talking about labor, not about menstrual cycle. So if it was, the question was menstrual cycle, then it could have been endometrium could have been the answer. But as we are talking about labor, the myometrium is the perfect answer. It's made up of 3 layers: the outer longitudinal layer, the middle layer, that is interlacing smooth muscle fibers. These interlacing smooth muscle fibers, they play a major role during the labor in contraction and retraction. So following delivery, by constricting the blood vessels passing through this layer, the bleeding from the placental bed is controlled. Thus, these muscles are also called as the living ligatures. This can be a question. What are the living ligatures in our body? Okay. So living ligatures example is going to be your myometrium. Why myometrium is otherwise called as living ligatures? Because following delivery, by constricting the blood vessels passing through this layer, the bleeding from the placental bed is going to be controlled. Thus, okay, see, in the myometrium there are few blood vessels. So these blood vessels, okay, is going to be constricting. Okay, because they are constricting, okay, the bleeding is going to be stopped. That is why it's known as living ligatures. The inner layer, if you look at the inner layer, is going to be made up of thin circular muscle layer. Now coming to the endometrium. The inner layer of the endometrium, which is going to be continuous with the mucosa and tubes of endocervix, is not much very important. So, what are the characteristic features of uterine contractions? So, there are 2 terms, okay? Contraction, retraction. So, what occurs during uterine contraction? The smooth muscle fibers shorten to a great extent than the striated muscle. The musculature of the upper segment undergoes a type of contraction called as retraction. So, the musculature of the upper segment of the uterus undergoes a type of contraction called as what? Retraction. So, retraction is also a type of muscle contraction of the upper segment. Retraction helps to maintain the uterine musculature in firm contact with the intrauterine contents and helps to prevent the fetus from slipping back up. At the same time, the lower segment relaxes and dilates. Its fibers become stretched with contraction of the upper segment, after which they do not return to their previous length. The lengthening of the muscle fibers of the lower segment is accompanied by the thinning of the lower uterine segment to only a few millimeters. As a result of the thinning of the lower uterine segment and the concomitant thickening of the upper segment, there is a ridge formation. And what is this ridge known as? Physiological retraction ridge. So these are the two things you need to know. There is some two terms known as contraction. What is contraction? Contraction is nothing but the smooth muscle fibers. The smooth muscle fibers will be shortening. Okay, they will be shortening. That is contraction. What is retraction, guys? So the upper segment of the uterus also undergoes a type of contraction, and that is known as retraction. So the retraction is very important because it maintains the uterine musculature overall. And the third thing that you need to remember is there is something called as a ridge formation. Okay, and that is nothing but this physiological ridge formation is known as physiological retraction ring. Okay, so ridge formation on the inner uterine walls. So ridge formation in inner uterine walls is otherwise known as the physiological retraction ring. So these are the 3 points you need to remember. So gradient of diminution physiological activity. If you look for labor to progress, so what do you mean by gradient of diminution physiological activity? Guys, for labor to actually progress, the contractions of the fundus, if you look, it must be strong and sustained, with less strong simultaneous contractions of the middle zone and relative inactivity of the lower parts. Okay, so for a labor, so this is your uterus, guys. Okay, so this is your uterus and the baby is over here. Okay, so this is your baby. So what is labor? This baby should be delivered, right? That is the process of labor. For this baby, okay, to be delivered, what should happen, guys? This is the lower segment. Okay, this is the lower part of the uterus, and this is the middle zone, and this is your upper zone. So basic common sense says that the middle zone, if it contracts, and if the lower part relaxes, or is it or if the low, in other words, if the lower part is inactive and in the middle zone we have contractions, this baby can smoothly be delivered. So what does it mean? In middle zone the activity is more, and in the lower part the physiological activity is less. That is why this labor process is otherwise known as gradient of diminishing physiological activity. What is it known as? Gradient of diminishing physiological activity. So what are the characteristics of labor contractions? Characteristics of labor contractions. In labor, there is a fundal dominance with a diminishing gradient of activity from the fundus through the body to the lower uterine segment. Polarity is maintained. Contractions are accompanied by retraction. So uterine contractions during pregnancy and labor, if you see from early pregnancy, this is a very, very important term, guys. This is an MCQ, favorite MCQ. So what are the uterine contractions in early pregnancy known as? This is the question. So what are the uterine contractions in early pregnancy known as? It is known as Braxton Hicks contractions. Braxton Hicks contractions. Braxton Hicks contractions. Now, as pregnancy, this is when do you get these contractions? These uterine contractions during early pregnancy is otherwise known as Braxton Hicks contractions. As pregnancy advances, it is going to be converted into something known as the true labor pains at the onset of the labor. So the uterus has a baseline intrauterine pressure of around 5 to 10 mm of Hg at term. Okay, this is at term. Term means 37 to 42 weeks of gestation. So during the term, that is 37 to 42 weeks of gestation, the baseline intrauterine pressure is going to be around 5 to 10 mm Hg. And pain is going to be felt by the woman if the intrauterine pressure exceeds 15 mm Hg. This is an MCQ. So, when does labor pain occur? When does labor pain occur? Labor pain occurs when intrauterine pressure exceeds 15 mm Hg. That is when labor pain occurs. So, in early labor, the contractions occur every 3 to 5 minutes with a pressure of 20 to 30 mm Hg above the resting tone. So, uterine contractions during pregnancy and labor, there are 4 important MCQs. So, in early pregnancy, what occurs is, if in early pregnancy the contraction occurs, it is known as Braxton Hicks contraction. And as the pregnancy advances, true labor pains start. So, the uterus has a baseline intrauterine pressure during term is going to be 5 to 10 mm Hg. This is the baseline. And when will the pain be felt by the woman? The pain will be felt, the labor pain will be felt when the intrauterine pressure exceeds around 15 mm Hg. So, recordings of uterine activity can be done by abdominal palpation of contractions. Very, very important machine, that is the cardiotocography. This can itself be an important short note. What is cardiotocography? So, this is cardiotocography machine is important. Cardiotocography, recording of the intrauterine pressure can also be carried out using an internal tocography. So, what are the factors influencing the initiation of labor? This can be a short note. This image is very important for the memory. So, the factors influencing the initiation of labor. So, first, fetal factors, placental factors, maternal factors. Okay, so there are three factors. So first, the anterior pituitary gland, right, will be having the there will be increase in adrenocorticotropic hormone, and adrenocorticotropic hormone will act on the adrenal gland. Similarly, when ACTH acts on adrenal gland, progesterone will be decreased. If progesterone is decreased, then the uterine sensitivity to stretching will be increased. And when the uterine sensitivity to stretching is increased, uterine contraction occurs, and that contractions will lead on to labor. Similarly, glucocorticoids and androgens also act on the adrenal gland, and when glucocorticoids and androgens are increased, what occurs? Estrogen also is going to be increased. If estrogen is increased, prostaglandins will be increased. If estrogen increases, the PGs, prostaglandins, will also be increased. These prostaglandins are the major factors that are going to soften the cervix. So, these prostaglandins will be causing increase in uterine sensitivity to oxytocin and increased stretching. So what is the power of prostaglandins is the uterine sensitivity to oxytocin will increase and the stretching will also increase, leading on to uterine contractions, and which is going to be again resulting into the process of labor. Now, very important role of this oxytocin is, this oxytocin, what it happens, this oxytocin will again act on the posterior pituitary, and posterior pituitary, it's going to give a positive feedback. So because it's giving a positive feedback, more oxytocin will also be released, and further more oxytocin, more contractions, more oxytocin, more contractions. So therefore labor is going to occur. The final pathway in the onset of labor is the release of prostaglandins. So just prostaglandins are our heroes. So finally, among all the mechanism, both androgens, glucocorticoids, adrenocorticotropic hormones, all of these hormones are further on going to be stimulating which one? They all will be estrogen will be released. Estrogen will also cause prostaglandins. More prostaglandins are going to be produced, and more prostaglandins, oxytocin is going to be released, and oxytocin will cause uterine contractions and causing to labor. So prostaglandins occurs following a series of events. Okay, now let's look at that sequence of events that is going to be taking place in initiation of labor. All we are talking about is the initiation of labor. So there is going to be a shift from the progesterone to estrogen dominance. So during labor, every time we know that the main hormone that is regulating the pregnancy, or the regulating hormone of the pregnancy, is going to be your progesterone. But during labor, for the baby to be delivered, is going to be a shift from progesterone. This is the first step in labor. There will be, for labor to occur, there should be a shift from progesterone to estrogen. This is the first step. Progesterone should be, the progesterone dominance should not be there. Rather, the estrogen dominance should be there. Secondly, there is going to be an increased responsiveness to oxytocin. Very important. For uterine contraction occurs, there should be increased oxytocin due to increase in the myometrial oxytocin receptor, and increased prostaglandin synthesis in uterus. This is the third point. Increase in prostaglandin synthesis in uterus should occur. And the fourth point, increased myometrial gap formation. Fourth point is increase in myometrial gap formation and decreased nitric oxide activity. Fifth point, decrease in the nitric oxide activity. And the last point is increased influx of calcium into myocytes, inducing myometrial activity. Increased influx of calcium into myocytes. Therefore, the myometrial activity will be increased. So, a short revision, guys. I am going to tell about the 6 sequential events that is occurring in the initiation of labor. Very important. So, first, the progesterone dominance should be converted into estrogen dominance. More oxytocin is going to be produced. Is going to be the responsiveness to oxytocin is going to be increased. Therefore, there are going to be increased prostaglandin synthesis. Fourth one, there is going to be increased myometrial gap formation. So, but nitric oxide activity should decrease. And remember, all will be, for initiation of labor, all should be increased. Okay, except for nitric oxide. Nitric oxide activity alone should be decreased, and because of increase in influx of calcium into the myocytes, the myometrium will be stimulated for contractions. So that's why myometrium is the very important muscle taking part in labor process. So what is going to be your fetal contribution? So whatever we studied this the initiation of labor, these 6 things, these 6 points are going to be supporting your maternal factors, right? This is all occurring in the mother's uterus. Everything is occurring in the mother's uterus. So now we need to move on to the fetal contribution. As the fetus matures, there is activation of the fetal hypothalamic pituitary adrenal axis, that is your HPA axis. Your HPA axis, which leads to a surge in the adrenal cortical production. Okay, see, fetus maturation, it targets the HPO. The HPA axis is going to be stimulated. Okay, it's going to be activated. What happens when the hypothalamic pituitary adrenal axis is stimulated? Of course, there will be increased in adrenal. Okay, adrenal cortisol production is going to be increased. Now, this fetal cortisol acts by stimulating the activity of placental 17 alpha hydroxylase, 20 lyase enzyme, pregnenolone estradiol synthesis of uterine prostaglandins, culminating in labor. So the three enzymes to be remembered are 17 alpha hydroxylase, 20 lyase enzyme. All these are important, okay, and pregnenolone. So these three are important. And now coming to the fetal cortisol. Fetal cortisol is nothing but it's a corticotropin releasing hormone, CRH, and oxytocin and prostaglandins. Okay, so these three will come under what? So the question is, what are the fetal cortisols? Corticotropin releasing hormone, oxytocin, and prostaglandins are fetal cortisol. So besides fetal cortisol, also prepares the fetal organs, fetal lung maturation. So this is another important point. The fetal cortisol also helps in the maturation, lung maturation, which is very important. Lung maturation is important. Fetal lung maturation, for fetal lung maturation to occur, fetal cortisol is important. In women with anencephalic fetuses, the pregnancy is going to be prolonged due to hypostatic adrenals. What are the roles of hormones in labor? So we have these two hormones, estrogen and progesterone. So the estrogen lowers the resting potential and increases the contractility of the muscle. Estrogen along with prostaglandins stimulate the formation of gap junctions. Estrogens have been shown to labilize the intracellular lysosomes and increase release of phospholipase A2 enzyme, which is essential for the initiation of prostaglandin synthesis. Estrogen increases the formation of oxytocin receptors in the myometrium. This is something important. The estrogen, what it does is, it helps in the formation of oxytocin receptors, that is in the myometrium. Coming to progesterone, the progesterone raises the membrane potential and makes the muscle quiescent. It downregulates prostaglandin production, oxytocin receptors and calcium channels. Progesterone lowers the gap junction formation. So release of prostaglandins. So name some namely the important prostaglandins are PGE2 and PGF2 alpha. PGE2, PGF2 alpha. These two are major prostaglandins, taking part in labor. So PGE2 and PGF2 alpha, they cause uterine contractions, cervical softening and effacement. So what are the three things? They cause uterine contractions is important. So prostaglandin, E2 and F2 alpha will cause uterine contractions, cervical softening and number 3 is effacement. So these are the 3 points: uterine contraction, cervical softening, and effacement. So there is going to be a signal from the uterus, and glycerophospholipids will be released, and these glycerophospholipids, with the help of an enzyme phospholipase, will be converted to arachidonic acid, and therefore there will be prostaglandins E2 and F2 alpha releasing. So what are the role of prostaglandins? They form the gap junctions in myometrial cell. We already studied that gap junction formation in myometrial cell is important for labor, for the myometrium to contract. Now there is a coordinated uterine contraction in labor, activation of contractions, and cervical ripening. So the very important 3, what is the role of prostaglandins? Uterine contraction. How uterine contraction? By the formation of gap junctions. By the formation of gap junctions, uterine contractions are going to occur. And second one is prostaglandins cause cervical softening, or otherwise known as ripening. And third one is effacement. So coming to how these gap junctions are formed is, the prostaglandins are important for the formation of gap junctions. As we know, we already studied PGE2 and PGF2 alpha, the most important ones. Thromboxane and endopeptides also stimulate the gap junction, whereas the prostacyclin inhibits it. Gap junctions are cell to cell contacts at the plasma membranes of adjacent cells, which have pores to allow communication between cytoplasm of both cells. They facilitate the passage of current or metabolites between the cells. At term, the gap junctions increase during labor and begin to disappear within 24 hours. Gap junctions are also present in preterm labor, induced or spontaneous labor. So coming to the mechanical factors, first is your uterine distension. So as pregnancy nears term, uterine growth slows down, whereas the rate of the fetal growth increases. So there's going to be an increase in the intrauterine pressure. So intrauterine pressure increases. The resultant tension enforced on the uterine muscle fibers may by itself initiate labor. So what occurs next is, there is going to be a mechanical stretching of the myometrium. Myometrial fibers are going to be stretched. So the stretching of the lower uterine segment, I already told you, the lower uterine segment should be stretched so that the fetal head can easily be delivered. So pressure exerted by the fetal head on the paracervical nerve ganglia. This theory is supported by the efficacy of artificial rupture of membranes in the induction of labor at term. So how is going to be the nervous control during the process of labor? So the sympathetic adrenergic nerves, all the sympathetic adrenergic nerves travel via the superior and inferior hypogastric nerves, and it's going to show an inhibitory effect. Whereas the parasympathetic nerves travel from the second, third, fourth sacral nerve roots through the inferior hypogastric nerve to reach the uterus, and therefore it leads to uterine contractions. Uterine contractions result in visceral pain, which is going to be mediated by T10 iron, not important. So just remember sympathetic adrenergic fibers. So just remember, nervous control is just going to be sympathetic adrenergic fibers. Okay, and what fibers? Superior and inferior hypogastric. Parasympathetic nerves are going to be through via the sacral nerves, So parasympathetic nerves, sacral nerves, all will be causing uterine contractions, whereas adrenergic fibers will give a inhibitory effect. Sudden surge of adrenaline release may have an inhibitory effect on the uterine contractions and may cause a temporary cessation of labor pain. So just look at the beauty. Sudden adrenaline release, there is a sudden surge in adrenaline release, and because of this sudden surge in adrenaline release, it's going to be having an inhibitory effect of uterine contractions, and because it's having an inhibitory effect of uterine contractions, the pain is going to be reduced. So emotion of fright adversely affects a woman in labor, and this may be due to flooding of the system with adrenaline as a result of sympathetic stimulation by emotions. So that's why adrenaline has a very important role in labor. So what are the cervical changes in the initiation of labor? So during pregnancy, the cervix protects the fetus by remaining closed. It prevents ascending infection and also provides resistance to the pressure caused by, I told the Braxton Hicks contractions. During labor, the cervix undergoes effacement and dilates, and that is known as cervical ripening. So the structure of the cervix is actually made up of three components: the smooth muscle, the collagen, the connective tissue. The smooth muscle contained in the cervix do not play a major role in the ripening of cervix. So collagen, connective tissue, it is the ground substance, as we know, glycosaminoglycans. So coming to the process of cervical ripening. So what is the process of cervical ripening? So process of cervical ripening is, with ripening, cervical softening and flexibility increases. Collagen protein connections or concentrations will decrease. So the glycosaminoglycans that is the connective tissue, are associated with collagen breakdown, proteolytic digestion by collagenesis. So hyaluronic acid in cervix increases. There is a decrease in dermal sulfate. The water content of the cervix is also increased. This is the only three things that you need to remember. So how do you say that is the cervix is ripened? Or what do you mean by cervical ripening? Cervical ripening simply means that the hyaluronic acid in the cervix is going to be increased. So hyaluronic acid in the cervix is going to be increased. And number 2, there is decrease in the dermal sulfate. There is a decrease in dermal sulfate. And number 3, the water content of the cervix is increased. So hyaluronic acid, water content will be increased, whereas dermal sulfate will be decreased. So pregnancy maintenance and termination factors concerned with the maintenance of pregnancy are going to be the myometrial growth and increased myometrial compliance, increased placental progesterone. Resistance is offered by cervix due to collagen content. And factors that bring about termination of pregnancy is increase in uterine volume, decrease of placental progesterone with estrogen dominance, increase in prostaglandins and oxytocin receptors, cervical ripening due to decrease in collagen content. So what are the factors which will maintain pregnancy? What are the factors which will terminate pregnancy? So myometrial growth, placental progesterone, collagen content in cervix, all these will maintain pregnancy, whereas increased uterine volume, just opposite, the placental progesterone, decrease in placental progesterone, increase in oxytocin receptors, and decreased collagen, all will be factors for termination of pregnancy. So next, coming to the most favorite topic, Very, very important question, all-time question. What are the stages of labor? What are the stages of labor? So guys, we have, in brief, we have 4 stages of labor. 4 stages of labor. First stage, second stage, third stage, fourth stage. So the stages of labor in brief. Stage 1. What is stage 1 of labor? So stage 1 of labor is very simple, from the onset of the uterine contractions. So from the onset of uterine contractions till the full dilatation of cervix. So till the full dilatation of cervix is going to be your stage 1. Stage 2. From the full dilatation of cervix, till your delivery of fetus, is going to be your stage 2. Stage 3, from delivery of fetus to delivery of placenta, is going to be your stage 3. And stage 4 is going to be simply but nothing but the observation. You are just going to observe the patient, observe the woman for 1 hour. Why are you observing for 1 hour? There might be either some physiological chills can be there, and can be seen in the 4th stage of labor. So you need to observe. So for stage 1 is onset of contraction, uterine contraction till full dilatation of cervix. Stage 2 is from the full dilatation of cervix till the delivery of the fetus. Stage 3 is from the delivery of the fetus to the delivery of the placenta, is your stage 3. Stage 4 is observation 1 hour. The most always favorite questions are going to be from your stage 3. What is the treatment of plan of management in stage 3 of labor is always the favorite question. So we'll be studying about that also. So this is in brief, guys, the stages of labor. So the labor process generally can be divided into two, okay? Pre-labor process and labor. So pre-labor is nothing but the period of increased uterine activity that takes place in a few weeks before the onset of labor. It is associated with some cervical softening and effacement. This preparatory stage of labor may begin about 2 or 3 weeks before the onset of labor in a primigravida and a few days before a multigravida. So the events taking place in pre-labor is going to be your cervical ripening, the descent of fetal head into the pelvis, increased frequency of micturition, lightening. On examination, there is going to be falling forward of uterus and shelving demonstrated. So during this time, engagement of the fetal head may take place in primigravida. Pre-labor. So the events taking place in pre-labor, if there is a question in pre-labor, what are the events taking place? First is going to be cervical ripening. First event is going to be your cervical ripening is one answer, and increased urination. Third is going to be engagement. So very favorite questions of the examiners is engagement occurs during pre-labor. So labor events are strong uterine contractions, progressive dilatation of the cervix, blood-stained show, rupture of membranes, descent of the presenting part. So this is going to be the order. So coming to this is a very, very important question. How do you differentiate between true and false labor pains? How do you differentiate So question is, differentiate between true and false labor pain. In women presenting with labor pains, true labor pain should be differentiated from false labor pains. So we know in in the early initiating period of labor, the contractions are known as Braxton Hicks contractions. Very important, Braxton Hicks contractions. It is usually Braxton Hicks contractions usually occur no more than few times per day. It's going to be irregular, so it's going to be less than 2 times per day. First point, it's going to be irregular and do not increase in frequency with increasing intensity. So it's going to be irregular and it does not increase with increasing the intensity. It resolve with ambulation. Very important. It can resolve with ambulation and it is not associated with cervical changes. Very, very important point. Not associated with cervical changes. Frequency will not increase with increase in intensity. It was going to be irregular. It will resolve with ambulation is important, and it is usually less than 2 times a day. These are the characteristics of Braxton Hicks contractions. Okay, Braxton Hicks contractions. So these are the features of false labor pains. So now coming to the contractions associated with labor, that is the true labor pain. True labor pain. So true labor pain may start as infrequently as every 10 to 15 minutes, but usually accelerate over time, increasing to contractions that occur every 2 to 3 minutes. It tend to last longer, become regular, and are more intense. It's more in intensity. This is irregular and less intense. Braxton Hicks contractions are irregular and less intense, whereas the true labor pain is going to be more intense as compared to the Braxton Hicks contractions. Braxton Hicks contractions will resolve with ambulation. Okay, this is your false labor pain. It resolves with ambulation, whereas true labor pain does not resolve with ambulation. Braxton Hicks contractions are associated with cervical changes, whereas the true labor pain leads to mainly the cervical changes. So there will be cervical changes. It does not resolve with ambulation. Very intense, and every 10 to 15 minutes it will be there. Increasing to that occurs every increasing to contractions that occur every 2 to 3 minutes also. So the first stage begins with regular uterine contractions and ends with complete cervical dilatation at 10 centimeter. So complete cervical dilatation is going to occur around 10 centimeters. That is when you say the cervix is completely dilated. So 10 centimeter is important. So during 12 hours in primigravida and 6 to 8 hours in multigravida. So the first stage duration, if they ask, the first stage duration is going to be, if it is a primigravida, it will be around 12 hours. If it's multigravida, it will be around 6 to 8 hours. The first stage of labor is divided into a latent phase and an active phase. So the first stage of labor is divided into a latent phase and active phase. Very important, guys. Latent phase and an active phase. Latent and active. So what is this latent phase? The latent phase is associated with mainly discomfort, mild and irregular uterine contractions that soften and shorten the cervix and result in cervical dilatation even up to 4 to 5 centimeter. Whereas in an active phase, the contractions become very rhythmic. and stronger and begin at about 5 to 6 centimeter of cervical dilatation and characterized by rapid cervical dilatation which is going to be complete at 10 centimeter and descent of the presenting fetal part. So in latent phase, very simple guys, what occurs first stage of labor. So we are talking about the first stage of labor. First stage of labor has a latent phase and it has an active phase. So what occurs in latent phase? There is going to be discomfort and mild to irregular uterine contractions will be there. Uterine contractions, and the cervix will be dilated to 4 to 5 centimeter. Whereas in case of active phase, it starts with cervical dilatation at 5 centimeter only till it reaches 10 centimeter. So it's going to be a rapid cervical dilatation, and there is going to be your presenting fetal part also is going to be there. Presenting fetal part, descent will be there. So descent of presenting fetal part. So this is all about the first stage of labor. So the main events taking place in first stage of labor: uterine contractions progresses from every half an hour to every 3 minutes with intermittent relaxations of the uterus. Each contraction lasts for about 45 to 60 seconds, and at the end of the first stage of labor, it may last around 60 to 90 seconds. Next, coming to the intrauterine pressure, IUP, intrauterine pressure. It increases from 5 to 10 mmHg to 5 to 20 mmHg. So in active labor, contractions occur usually every 2 to 4 minutes with pressures of 30 to 50 mmHg above the resting tone. So what is going to be your nature of labor pain? The labor pains are felt first at the back. So the women usually complain of back pain. Back pain is a complaint, and sometimes in the sacral region, and later they radiate into lower pain. So back pain radiating to lower abdomen is the usual complaint of the women. Back pain radiating to lower abdomen. Sometimes, rarely, to the legs also. So coming to the formation of lower uterine segment. Formation of lower uterine segment starts to form around 28 weeks of gestation. It measures around 7 to 10 centimeter and develops from the isthmus, and then effaced and dilated cervix is going to be there. There's an effaced and a dilated cervix. This is the formation of lower uterine segment occurring around 28 weeks and for 7 to 10 centimeter. So coming to the lower segment in labor, the upper segment is thicker and more active. The lower portion, this is the same, repeatedly I am telling. Upper portion will be active, lower portion will be, this is general common sense. Lower portion will be very passive. Why? Because it should be, there must be an easiness in the fetal head to descend. So the junction between the upper and the lower segment is characterized by this is important MCQ. So the junction between the upper and the lower segment is characterized by the physiological retraction ring. Again I am repeating this for the second time. Physiological retraction ring. If you see this image, 6 weeks, how is the cervix? 10 weeks, 16 weeks late, and late pregnancy. So this is how it's looking, the lower uterine segment. How it is dilated. Cervical changes. First, cervical effacement. So what do you mean by the term cervical effacement? Cervical effacement is the progressive shortening of the cervical canal to a thin circular opening at the external os. So, what do you mean by cervical effacement? It is the shortening. This is the cervical canal. So there is going to be shortening of cervical canal will be there. Shortening of cervical canal to a thin circular opening at the external os. Shortening of the cervical canal to a very thin, this is your external os, to a very thin circular opening. This is known as cervical effacement. Next, coming to dilatation of the cervix. The uterine contractions causing pressure on the membranes and the hydrostatic action of the amniotic fluid also dilates the cervical canal. So coming to the process of cervical dilatation, the process differs in primipara and a multipara. The dilation occurs progressively from above downwards, the internal os dilating first, then the cervical canal, and the last is going to be external os. So this is how the cervix looks before labor. See, there is widening and shortening. This is the cervix, and look at now the cervix has been shortened. The shortening of the cervix is nothing but effacement, early effacement. This is before labor and effacement and beginning of dilatation. So see, just look, from this is your cervix length, it is very shortened, and this width is more. So there is both effacement, that is cervical shortening is also there, along with dilatation. So complete effacement, see, this is your complete effacement in primipara, whereas in a multipara the complete dilatation is going to be like this. So coming to the pattern of cervical dilatation. So this is cervical dilatation in and this is labor in hours, cervical dilatation in centimeter. So during latent phase it goes like this, and active phase, the cervical dilatation in labor it's going to be rapid. So in active phase you have a rapid cervical dilatation. Pattern. So Friedman explained that the cervical dilatation that takes place during labor takes a shape of a sigmoid curve. This curve, so cervical dilatation, this is your Friedman's sigmoid cervical dilatation curve. So the active phase is subdivided into an acceleration phase, which means phase of maximum slope, in which there is a rapid dilatation as said of the cervix, whereas the deceleration phase, this is your deceleration phase, guys. So this is your deceleration phase, during which there is slowing down of cervical dilatation. So the active phase in labor is expected to dilate at a rate of 1 centimeter per hour. Very, very important MCQ. In active phase of labor, the cervical dilatation rate is 1 centimeter per hour. 1 centimeter per hour. Okay. So mucosanguineous blood strange. What is show? Very important question. These are all very favorite Viva questions. What is show? What is show? Show is nothing but a mucosanguineous sanguineous blood stain discharge. During labor, mucosanguineous blood-stained discharge is called as show. So very important Viva question. What is show? Show is nothing but during the process of labor or during labor, there is going to be a mucosanguineous blood-stained discharge. That is known as show. So with cervical effacement and dilatation, the mucus that is going to be found in the cervical canal separates, and this mucus is going to be passed. It is sometimes blood-stained due to disruption of capillaries. So how do you get mucus? Because of cervical effacement and dilatation. In the cervical canal, mucus is going to be released. Along with the mucus being released, some capillaries are going to be disrupted. Therefore, it is mucosanguineous blood-stained discharge. That is show. Next, coming to rupture of membranes. There is a spontaneous rupture of membranes. Usually occurs in the course of active labor. So, with the increase in the hydrostatic pressure, the membrane eventually ruptures. In a vertex presentation, as the head fits well in the lower segment, the membrane is applied to the head, whereas in mall presentations, the membrane will be hanging loose. Next, the seventh event in labor is the fetal descent. In nulliparous, the engagement of the fetal head usually takes place before the onset of labor. Non-fixation of the head in cephalic presentation suggests the possibility of abnormalities. Active descent occurs during the phase of maximum slope of cervical dilatation and continues in the second stage of labor until the head reaches the perineum. So next, coming to the second stage. So we completed the first stage of labor thoroughly. So now let's move on to the second stage of labor. So the second stage is nothing but the stage of, as I told you, first stage we finished from the stage of contraction, uterine contraction, to the cervical dilatation. Full cervical dilatation is achieved at 10 centimeter. Till that, the process is going to be first stage. Now from the stage, now the cervix is dilated. So from the complete dilatation of the cervix to the expulsion of the fetus, it's going to be your second stage. From the expulsion of fetus to the expulsion of placenta will be your third stage, and fourth stage is just observation. So the second stage is nothing but the stage of expulsion of the fetus and extends from complete dilatation to expulsion of the fetus, as I told you. So it lasts for around how many hours? 1 to 2 hours in case of primary gravida. Whereas in a multipara, the labor duration is going to be reduced. Obviously, they've already been pregnant once, right? So the labor duration will be reduced. That is half an hour to 1 hour. If regional anesthesia is used for pain relief, the duration of second stage may be 2 to 3 hours in primary gravida and 1 to 2 hours in multi. So the second stage of labor is divided into a pelvic phase and a perineal phase. Okay. So first stage of labor, how did we divide? We divided into a latent phase and an active phase, right? And we also had a Friedman sigmoid curve. Okay, this is your, we drew this Friedman sigmoid curve, dilatation curve, and you have this active phase, latent phase. And now moving on to the second stage of labor. Similarly, there are again two phases. One is the pelvic phase, and number 2 is perineal phase. Pelvic phase, perineal phase. So in pelvic phase, what happens is the head reaches the pelvic floor and maximum fetal descent occurs. So in pelvic phase, the head reaches the pelvic floor, and as the head reaches the pelvic floor, maximum fetal descent is going to occur. In case of a perineal phase, bearing down contractions take place. Okay, the bearing down contractions take place and the head reaches the perineum. So, when the fetal head, guys, simple, very simple, pelvic phase is nothing but when the fetal head reaches the pelvic floor, that is pelvic phase. And when the fetal head reaches the perineum, it is nothing but the perineal phase. Uterine contraction occur every 2 to 3 minutes and lasting from 60 to 90 seconds. They are more severe than the first stage and are of bearing down character. Very important. In second stage, what is the character of uterine contractions? So uterine contraction character is going to be bearing down character. It's going to be a bearing down character. The diaphragm and the abdominal muscles begin to act with pushing. Intrauterine pressure, IUP, will be rising up to 100 and 150 mmHg. With each of these pelvic pains, the fetus is pushed down through this dilated cervical canal and the vagina relaxes and dilates to receive it. So when the perineum is going to be stretched, so it begins to bulge with each uterine contraction. Next, crowning of head occurs. Crowning of head is said to have occurred when maximum transverse diameter of the fetal head stretches the vulval outlet and does not recede in between contractions. So when do you say crowning of head? When the maximum transverse diameter of the fetal head, that is biparietal diameter. Okay, maximum transverse dia is nothing but the biparietal diameter passes through the vulval outlet. That is when you say crowning of head. So at this stage, the woman feels an inclination to micturate and defecate. So this is due to the pressure of the presenting part of the bladder and rectum. Lastly, the head passes through the outlet with a series of almost continuous uterine contractions helped by involuntary straining efforts on part of the woman due to action of the accessory muscles of the labor. So as the expulsion of the head takes place, the woman exerts one last effort and thereafter the result of the fetus is born. Next, coming to the third stage. So the third stage of labor is nothing but the stage of placental delivery. So the average duration is very few minutes. Around the third stage average duration is around 15 minutes. The third stage of labor is considered prolonged if the placental delivery does not take place in 30 minutes. So if not within 30 minutes, then the third stage is going to be prolonged. That is when you say prolonged. So it should occur within 30 minutes, mostly 15 minutes itself. The placenta will be delivered. So events occurring in third stage of labor. First event is characteristic uterine contraction. Second event is separation of the placenta. Third event is expulsion of the placenta. First separation will occur and after separation only expulsion occurs. And fourth, control of hemorrhage. And fifth, permanent contraction and retraction of the uterus. Permanent contraction and retraction of uterus. So events occurring in third stage of labor are uterine contractions, separation of placenta, expulsion of placenta, control of hemorrhage, permanent contraction and retraction of the uterus. So there are two methods by which placental expulsion may occur. So placental expulsion. So placental expulsion occurs by two methods. First one is Duncan's method. Duncan's method. So what is Duncan's method? Due to contraction of the uterus, okay, so the uterus are contracting. So due to contraction of the uterus, the placenta may fold on itself. So placenta will fold on itself, okay, fold on itself, and separation will begin at the periphery, okay. So this is the process of placental separation, guys. So in placental separation, what happens? The placenta will fold on itself due to what? Uterine contraction. See, the uterus is contracting and the placenta will fold on itself, and because the placenta folds on itself, it will be separated, and this begins from the periphery. So then the placenta descends sidewards so that the long axis of the placenta corresponds to the long axis of the uterus. Very important. The long axis of the placenta will be corresponding to the long axis of the uterus, and the lower margin of the placenta presents at cervix or vagina. Next method, this is the Duncan's method. So Duncan's method, simple, is nothing but placenta fold on itself, and therefore leading to placental separation. And then the placenta will descend sidewards, and the long axis of placenta and long axis of uterus will be parallel, and therefore placenta will be expelled. Now next method is Scull's method. What is Scull's method? Scull's method, the placenta separates at its center. So guys, in case of Duncan's method, the placenta will separate from periphery, whereas in case of Scull's method, the placenta starts separating from the center. That is the two big difference. Very, very important. So Scull's method, in Duncan, it's going to be from periphery. In Scull's, it's going to be the placental separation will occur from the center. So due to the separation, retroplacental hematoma. Okay, very important complication. So retroplacental hematoma develops, which with each contraction of the uterus forces more of the placenta to separate like an inverted umbrella. So if you look at this figure, this is the placenta. So the placental separation starts from the center. Okay, that is why this is Scull's method. So Duncan's method is from periphery. The placenta will fold on itself and placenta will be separated. Whereas in case of Scull's method, it's going to placenta will be starting to separate from the center. So this is all the two methods of placental expulsion. This is a question. Expulsion of placenta usually occurs within few minutes after birth of the fetus. During this period, the uterus should be moderately hot in terms of tonicity so that the placenta separates, and the contraction and retractions of the uterus will arrest the hemorrhage by closure of placental sinuses. Now next, coming to control of hemorrhage, contraction and retraction of the uterus, occlusion of the torn vessels themselves, formation of blood clots which favor the closure of the lumen of the vessels. Bleeding in a normal patient does not exceed 250 ml. Okay, and following labor, the women may occasionally have a physiological chill. This physiological chill occurs during the observation period. That is the fourth stage of labor. So that's it, guys. So any questions regarding the causation and stages of labor? Any questions, you can post it on the comment section. So yeah, thank you.